This is Professor Vicky Karku. I'm a professor of arts and wellbeing and the director for the Research Center for Arts and Wellbeing. Today is the annual address for Health Research Institute, which is supported from the Research Center as well. I'm here introducing James Sanderson. And I'm introducing James Sanderson because it was, sort of an invitation I made towards him as the person who I regarded as the architect for social prescribing nationally and internationally. So we're very privileged to have James here. I let him know that I'm going to introduce him as the architect for social prescribing, and he half objected to that, stating, well, I was more of a builder, had my hands in. Oh, I also put curtains and flowers around the decoration of the construction. So a lot of different roles, right, within that thing. But that's not the only thing that James is doing. Also, whatever it seems James is touching on, it becomes a national priority, which is very much what he's doing now as the CEO of Community Health Services and Personalised Care for the NHS. We invited him for the annual address for the Health Research Institute, partly because Edgehill is committed to work with that has direct impact on people's lives, and certainly James has a lot to say about that. Because social prescribing and personalised care has shifted our thinking around how we perceive care and what we think about care and who has the knowledge around that, right? So I'm sure, I'll pass on to the content and the information about these two areas, social prescribing and personalised care, to James, who knows what he's talking about. I have that sort of the aftertaste, the leftover from his work. But before I do that, I'm going to read his biographical note. James Sanderson, this is an abbreviated biographical note, by the way. James Sanderson is the Director of Community Health and Personalised Care at NHS England, where he leads a range of programs supporting people to have greater choice and control over their health and well-being. These include delivery of the comprehensive model for personalised care, NHS at Home, and the National Palliative and End-of-Life Care Programme. In community health, it includes expansion and further rollout of virtual wards, urgent community response, anticipatory care, enhanced health in care homes, and intermediate care. From 2019 to 2022, James was also the CEO of the National Academy for Social Prescribing, and he came to that role making a major impact on it from a varied professional background, from accounting to car sales. But for me, the more appropriate and useful background he had was as an arts graduate. So I hope these was the seeds that kept the arts and revisited the arts as part of his more recent work. So I'm going to stop now, and I'm going to pass this to James. Thank you for being here, James. We're all ears.
Thank you very much. Morning, everybody. Gosh, it's always really tricky, isn't it, when someone reads out your bio? You think, oh my goodness, is that what I've got to do? It's quite scary. It's quite daunting, really. I've only got about 40 minutes. So what I was going to do, I was going to just give a little bit of context for social prescribing, and I'm going to start 4,000 years ago and work my way up to present day. So I actually think it gives me about 1 minute for every 100 years. I think that's about right, isn't it? If my maths works. But it'll be a bit of a potted history. Good morning. It's brilliant to be here in Edge Hill. What a fantastic campus and a brilliant university. It's so great. I've only just seen a little bit on my walk from the car, but I'm hoping to see a little bit more of the facilities later on. And welcome to everybody online as well this morning. So what I wanted to do is just set the context of why we need personalised care and how social prescribing fits into a modern day health system. That's what I was going to try and cover. But I did say that we'd start 4,000 years ago. And so when you look at health over the history of time, and you think about what have been the major leaps forward in relation to health. One of the first major leaps, I think, was about 4,000 years ago in Mesopotamia, Babylon, modern day Iraq, which was real start of civilization and modern civilization in relation to things like sanitation and clean running water. You know, they were one of the first civilizations to master that properly. And actually, you know, that's one of the biggest things that we can do for health, sanitation, clean running water, you know, huge benefits to us as human beings. It's really interesting then you look at what happened after that. So that's 4,000 years ago. It took until 1858 before the Victorians put a sewage system in London, and up until that point it was pretty putrid. I think they had a particular year where it was called the Great Stink, and actually conditions like cholera and typhoid were really rife, airborne diseases, because of the Thames being an open sewer system, you know, despite that learning many years ago. And actually you look back into other aspects of health, and you think, well, okay, if that's the first sort of leap, you know, sanitation, clean running water, that's a big leap forward. You know, what came next? And what came next was what we call modern medicine. You know, if you think about all of the things that have happened in the last 100 years, it's quite remarkable. It was fewer than 100 years ago that we discovered penicillin. It was 1928 that Fleming discovered penicillin. You know, we haven't had big things that we rely on nowadays in place for a very long time. It was the 70s when we developed MRI scanning. It was you know, only in the 1960s that we started looking at heart transplants. You know, things that we rely on now as being you know, cornerstones of our ability to fix people when they're broken have only appeared recently. The interesting fact about penicillin is that many of you will probably know this, but the Egyptians were using mouldy bread on wounds and binding it. So without knowing, they'd started using antibiotics back then, but you know, not until 1928 when we started that process of using them in medicine. So you know, that I think is the second biggest leap. You know, first water, sanitation; second, the development of modern medicine. However, what we face as a society now, I think, is something that's quite tricky, because whilst medicine is brilliant, drugs are great, you know, we still want that advancement, and there's some brilliant stuff happening now where precision medicine is concerned, you know, developing particular medicines that are linked to somebody's DNA, that, you know, linked to them individually, that are personalised to their genetic makeup. And I think that's an incredible leap forward in the way in which the future of biomedicine will progress. However, we're starting to see some of the challenges of that. We've got issues of antimicrobial resistance. We've got issues of addiction to opiates in a lot of countries, and antidepressants. We're seeing some of the potential harms of those as well. Alongside this, we've also got challenges, of course, of the social determinants of health, and many of you will be familiar with the work of Sir Michael Marmot, looking at the issues that people face in relation to good health and well-being, and you know, a 10 to 15 year gap in life expectancy between the richest and poorest in society, and also a 10 to 15 year gap in healthy life as well, not just in terms of overall mortality, but in terms of the number of years that you get of healthy life. And actually, in a lot of major cities around the country, you can plot some of that 10 to 15 years on a bus route, on a single bus route. Areas that are adjacent to each other, life expectancy reducing really significantly on the stops of that bus. Now, that is a real challenge for society. And Samir Gray, Professor Samir Gray, talks about the fact that you know, it's easy to be well, it's easy to be healthy. You just need to be born with the right amount of money in the right postcode area with the right genetics. And if you failed at that, then you know, it's your fault, of course, isn't it? So you know, that's a real challenge for us. You know, how do we get over that? How do we get over that position? So that's a bit of context. You know, whilst medicine is great, whilst biomedicine unlocks lots of great opportunities for us, there are limitations. There are limitations, and biomedicine doesn't tackle those social determinant issues. So what can we do about that? Well, what we can do about that is what I call personalised care. So this just provides a very simple overview of what we mean by personalised care. When I talk about personalised care, this isn't what some people refer to sort of very casually as person-centred care. Now, I think that term is actually quite odd, person-centred care, because we talk about we're delivering person-centred care in the NHS. Well, if we're not delivering person-centred care, who is it centred on? And of course, it's got to be person-centred. You know, that's just being nice to people. That's treating them well, treating them with respect. You know, we need to do that. That's a basic principle. But actually, when I talk about personalised care, I'm talking about something different. I'm talking about giving people choice and control over the way their care is planned and delivered, and that's based on what matters to them as individuals and looks at them as a whole person, looks at their whole lives, looks at the situation in which they're living. And this is really important because actually, when I talk about that challenge, I talk about the social determinants, we talk about the level of complexity that exists in society. A one-size-fits-all healthcare system just doesn't work. You know, we've got the brilliant system in this country. You know, the NHS is something to be proud of in so many ways. But actually, by and large, what we've got is a transactional healthcare system. You know, if you're broken, you go to a GP, you get fixed. If you're broken and you need something specialist, you go to a hospital, you get fixed. You know, that transactional nature of dealing with health, whether it's something as simple as needing a prescription to get over an infection, or it's something complicated like a broken arm, or something more complicated like cancer, you know, we can fix that. We can deal with those circumstances. But actually, we have a rise of people living with multimorbidity, you know, complex long-term conditions. That's one of the benefits of living longer. In 1948, when the NHS was created, a man of my age would have had life expectancy of 65 years. Life expectancy now has gone up to around 82 years. That's a 17-year shift in little over 70 years. The NHS will be 75 years this year old. You think about that, a shift of 17 years of life expectancy over the course of just a 75-year period. I mean, that's quite a significant shift if you think about how we've evolved as human beings and how life expectancy has changed over many thousands of years. So are we actually addressing that? Because what happens with that life expectancy, which is an amazing achievement, is that actually we're living with greater complexity where health's concerned. You know, conditions like dementia, as we know, conditions like type 2 diabetes, you know, things that start to go wrong with our bodies as we age. And actually we're seeing more and more people hit the system with that level of complexity. When we've just gone through, you know, a very busy period during winter, 50% of people in hospital were over the age of 65. And actually, 1 in 5 of them, 1 in 5 people in hospital over the age of 65 are in hospital not because of the conditions that they're living with, but because of the drugs that they're taking. And about a quarter of people that are in hospital have dementia. You know, is this the right setting? Is this the right setting for those individuals? So, you know, life expectancy improving massively, complexity also improving, increasing alongside that improvement trajectory. So this is where personalised care comes in. You know, how can we deliver something that's based on an individual circumstances? How can we tailor something to a particular need? Now, whilst I'm an advocate of personalised care everywhere, you know, we call it universal personalised care for a reason. I'm not naive in so much as there are some occasions where it doesn't work. You know, in some times we just want the NHS, we want healthcare professionals to do what they do best. You know, hopefully I'm not going to be knocked unconscious when I walk around the site later. But if I was, I don't necessarily want a paramedic or some of the paramedic students that I've seen walking in and out of the building today. I don't want them standing over me saying, you know, what matters to you? You know, what does a good day look like? You know, that sort of conversation is probably best left for other circumstances. So there is some bits of healthcare that actually we just want professionals to pick us up and help us out, and that's the nature. But actually, for certain conditions, then we need to be talking about how we can give people voice, because you know, clinicians will always be experts in conditions or diseases, but people are experts in themselves. People have lived with themselves for a long time. If you think about that, you know, we've all lived with ourselves since before we were born. It takes a while to think about that. We've all lived with ourselves before we were born. So that expertise that we have in ourselves is really important. So linking that expertise with the expertise of clinicians, I think is key to that. So alongside this, we created the comprehensive model for personalised care. So this model takes a whole population approach. And effectively what we were saying was we need to shift the way in which we're delivering outcomes for people. We need to look at different interventions. We need to try and find ways of creating a healthcare system that focuses on that need. So, how does this work in practice? Well, I was just giving an example when we were having coffee before we started this morning. If somebody is going to the doctors regularly, they're on prescription medications for steroids, for salbutamol, taking an inhaler because they have respiratory issues. We're giving them those drugs. We're giving those drugs to fixing the respiratory issues. But actually, is their respiratory condition caused by the fact that they're living in accommodation with black mold on all of the walls? That damp is causing their respiratory infection. Are we going to just continue giving them prescriptions for the rest of their life when they start to develop more and more significant issues with the respiratory illness? Or are we going to fix their housing? We fix their accommodation, fix the root cause of it. So, that's the sort of thing that we're wanting to shift. Let's shift the focus away from that very transactional, fix the thing that's in front of us, to looking at the whole person. So this is partly how the model works. But I just wanted to focus on the operating model around the way in which this should work. So we created this model with all of these zones. And the way in which we did this is, this has started in 2015. We started to think, well, actually, if this shift's going to happen, what's already happening out there? So we looked out across the country at what was going on. And actually what we found was there was a huge amount of really brilliant practice. There were clinicians, there were social workers, there were members of the public, there were community organisations, all working on shifting care in a different way. So, I'm not an architect of social prescribing. I think social prescribing was happening perhaps 35 years ago when I was working in different fields. And actually, pioneers like Michael Dixon in Cullompton in Devon and Sam Edrington in Bromley by Bow were practicing this as part of their general practice work 30 odd years ago. But also, alongside people practicing social prescribing, we've got clinicians in secondary care, we've got oncologists looking at consent and looking at shared decision making and looking at why people were choosing to go for certain treatments and why people weren't, and what the psychology was around that decision making process. So shared decision making was becoming a big thing. We'd also got personal health budgets, which was a movement really which had started in the 1970s, disability rights movement, nothing about us without us, disabled people wanting more control over the way their care was deployed, saying, actually, we don't just want services given to us, we want to create the packages ourselves. And what was really interesting was that whilst these things had grown up in very different spaces, we've got clinicians in hospitals, we've got members of the public calling for better rights, we've got GPs sitting in GP surgery. What was the essence of that was all about how we can improve individual skills, knowledge and confidence, how we can improve the agency that people have. I'll ask you a question, a bit of audience participation. Sorry for this, but can you put your hand up if you like to be excluded from decisions that affect the most sensitive and intimate aspects of your lives? That's good. 100% of people believe in personalised care. That's great. That's great. We've got that. I think that meets all the research and academic criteria we have. It's really interesting. 40% of people say they're not as involved as they would like to be in their care. 40% of people living with a long-term condition lack the skills, knowledge and confidence to manage that condition. And 40% of people don't understand the health information that we provide them with. And interestingly, that goes up to 60% if it's numerical information that we provide people with. There's also an interesting thing there about the fact that if you want to quote statistics, quote 40%, and you'd probably get away with it. But yeah, I always think that's really stark, thinking about how significant that link is. So if people are experiencing this challenge where the health information they're being provided, the health information they're being presented with, they're not necessarily understanding, they're not as involved as they would like to be in the decision making about their care and treatment options. What can we do to shift that focus? So the first element of that is actually dealing with shared decision making. So it's a key entry point to this, as you'll see in the top left hand box, shared decision making. So having a different conversation. Now, this is something that needs different forms of training, actually, because clinicians aren't necessarily trained in shared decision making, having that clinical conversation, shifting that focus to the individual. So starting with what matters to you conversation, not just focusing on treatments, not just focusing on what's wrong with people. And interestingly, shared decision making is evidence to provide some really different shifts. So if people are fully informed by the issues that they're faced with, they'll actually, 20% of them will choose less costly, less risky interventions. So on big pathways, and we've done some work looking at people on waiting lists for musculoskeletal areas of support, and actually you can take around 7 to 10% people off the list just by having a different conversation with them, just by looking at different treatment options. And we've started to see this now in clinical practice. Is somebody going to manage their arthritis through injections into their hip, or are they going to manage it through going swimming? How are we going to treat that issue that people are living with? So trying to find different ways, different routes, and I think that's really interesting, just having that conversation. And actually, when we talk about technology improving healthcare, conversation is probably one of the biggest technologies that we have, and we don't necessarily deploy it in the right way. So linked to this is personalised care and support planning. So are we really impacting on people by developing a effective plan that looks at their whole life, creating that plan for them across everything? Now, again, one of the problems that we've got, I think, in healthcare systems, not just in this country but around the world, is that we have become very siloed in clinical specialisms. We assume that someone has cancer on a Tuesday and mental health issues on a Wednesday. They can't have cancer and mental health issues on the same day, because that's not when their appointments are. That's not how the system's structured. But of course, people are living with all of those things on a daily basis. So bringing together a personalised care and support plan is really important. And actually, it's not just about living with a long-term condition. Also, when we talk about palliative end-of-life care, when we look at advanced care planning for end of life, we can give people a better death. We can give people a better outcome by having a plan in place. On average, if somebody doesn't have a plan, in the last 12 months of life, they could have up to 9 admissions into hospital during that last 12 months. If there's a care plan in place, it's reduced to just 1. And people don't want to be spending their last few days going into and out of hospital, or the last year of life going in and out of hospital. So, that planning perspective at all parts of the system is really important. And again, you look at the other end of the scale, in maternity services, having personalised care and support plans for people going through maternity services, ready to have a baby, developing a plan for their wishes is incredibly important as well to bookend that process. Then beyond this, so we said, well, actually, if these are the shifts that are starting, this is starting a conversation, how do we then deliver a different service? And we started with looking at self-management support. So this sort of box there to the second from the right, self-management support. How do we increase skills, knowledge and confidence? How can we give people the opportunity to have better outcomes? Back to what I was saying initially, if you look at that health differential between the richest and the poorest in society, the 10 to 15 years gap, one of the things that seems to be missing there is agency, which is not necessarily the best term. But actually the level of activation that people have, the way in which they're aware of their health, and also the connections that they have. And the evidence here is pretty strong. If you shift someone from being very low levels of activation to being very highly active, knowing about their health, understanding their health, understanding how various things impact on them, you can move the way in which they utilise services in the system. So if you move someone from level 4 to level 1, you've got a shift of about 19% reduction in GP visits, about 38% reduction in admissions. So if somebody develops a long-term condition, for example, somebody's newly diagnosed with type 2 diabetes, why are we not sending them to college to learn about their diabetes, online training, support? Why are we not connecting with a peer, somebody that's lived with the condition for a few years that can support them through what they're experiencing, rather than just packing them off with a prescription and a diagnosis, trying to get people to be able to manage that condition much more effectively. And then alongside this, I mentioned briefly personal budgets in terms of the disability rights movement. We now have 150,000 people receiving personal health budget. It's quite small scale still, it could be a lot bigger. But actually that's been really revolutionary, especially for disabled people, especially for people living with really significant support needs. So, just one example of this, somebody living, requiring 24/7 care, requiring people to provide personal and domestic care, on average, they could be getting about 30 to 35 care agency workers a year to provide their care and support. So on any given day, they may have a total stranger turn up to their house to provide them with some of the most sensitive support. But actually, personal health budget, giving that person control, enabling them to employ carers that relate well to them, that share their hobbies and interests, that want to do the activities that they like to do during the day. Trying to give them that opportunity to create that package in place. They can perhaps employ a team of 4 or 5 people that are consistent. It's cheaper, proven to be between 11 and 17% cheaper for the state to provide that sort of support. It's better for the individual because they're able to relate well to the person. It tends to be better for the carers because they're providing support to somebody that they relate well to as well. And actually, it helps with health issues as well, like continuity. Somebody who's providing the same care every day can spot issues that are going, like skin deterioration, for example, all sorts of other deterioration in people's conditions. So, that's really important too. And then, of course, we've got social prescribing, which I'll come on to in a bit, but just to briefly mention NHS at Home. So whilst all of this is about a shift in the way in which we speak to patients, the way in which we engage with patients, one of the things that we developed during COVID, when the first wave of the pandemic hit back in March 2020, was NHS at Home. So we noticed then that there were many people that were that unfortunately were dying because of silent hypoxia, a condition where actually your body is starved of oxygen, despite the fact that you feel pretty well. You feel like you're breathing normally, but your body's not absorbing the oxygen into your vital organs. So there's a really simple way to fix that. It's with a pulse oximeter that tells you your blood oxygen levels. Little device that you stick on your finger. You've probably all seen one. So we decided, actually, let's just get these out to people that are in high risk categories. Let's just give them a pulse oximeter and give them a really simple instruction to check their oxygen saturation levels. And if it drops below 95%, this is what you need to do. Really simple thing. And we deployed that. And we've actually now deployed that to over 700,000 people. We've got 700,000 oximeters there in circulation. But then from that, we thought, well, actually, what else is it that we could do? Why is tech held so tightly by the NHS? We've got many people living with cardiovascular disease, with hypertension, blood pressure monitors, fairly cheap, £45. Why don't we provide people living with hypertension a blood pressure monitor? So we've now deployed 220,000 blood pressure monitors of 1.8 million people that have supported themselves through taking their blood pressure readings. And actually, it can be more accurate. As somebody that's fairly inactive, going to the GP practice once a fortnight to get their blood pressure checked, their blood pressure is not normally right when they get to the GP practice. But actually taking it in their own home regularly on a daily basis, being trained to do that, we can get more accurate readings. So trying to find tech that will do that. And the other thing that we can potentially start to get into is the way in which we can do diagnostics at home as well. There's lots of things, again, that have been the preserve of GP practices, but how can we actually get those things out to individuals in the community to be able to diagnose certain things? Dipsticking urine, for example, in a GP practice, can we get people testing for UTIs, people that have regular UTIs, can we get them testing themselves in their own homes? And actually some of this has partly come from the energy that was released through lateral flow testing in COVID. If we just said 5 years ago, if I'd been standing here 5 years ago saying, in a few years' time, we'll have chemical laboratories in every kitchen in the country so that people can test themselves for viruses and then choose a course of treatment, we thought it was crazy. But actually what we've seen through that is the ability for people to start getting engaged in their healthcare. So, that's another thing that we've done through the NHS at Home piece. And then come on to social prescribing, the other part of this model. So this is my 3-4-3 diagram of social prescribing. So social prescribing, as I said, it's been around for, it's been around for generations and generations. Not just the 30 years that people have been practicing it in the NHS, but the concept of nature being good for us, the concept of movement, the concept of arts and culture. You think about the history of civilization, you think about arts and culture movements, you think about how important that's been for the development of civilization. I mentioned Babylon at the start, hanging gardens of Babylon, nature being incorporated into a city environment. It's quite an interesting thing when you think about how long that's been going on for as well. So what does this model show you as well? Actually, what we need for social prescribing is different entry points. So we need people to be aware, the whole population to be aware about how good these things are for our health. And I'm not sure whether we are. I'm not sure whether as a society we have actually grasped just how important these things are. We might do them, we might engage in them, but actually that conscious acknowledgement of how beneficial they are to health is something that we perhaps don't see very often. So the whole population, self-referring, getting people to engage with their health and say, actually, I'm going to do something to change my health. I'm going to engage in parkrun, maybe, which we were talking about this morning, around the Edge Hill campus, which I'm sure is beautiful, a beautiful run. You know, engage in parkrun, engage in activity, engage in arts. You know, how can we get people to move down that line? The second area is actually, we know that not everybody can just engage in those things. You know, that there might be barriers, there might be financial barriers, there might be societal barriers. If people have been isolated for many years, you know, how can we get them out? And that's where, you know, having community connectors come in, having people in various groups, in organisations that can bring communities together, that can bring people out to those activities. But then for people with really significant need, we need health professionals with that support as well. So we introduced, as part of the 2019 long-term plan for the NHS, the role of a link worker. And we now have over 3,000 link workers in place, about 3,200 link workers across the country. And these are people trained to sit in GP practices, or you know, about 3/4 of them actually are part of a GP practice, but sit in a community organisation. Link workers have the time in order to support people to connect to community-based activities. And the reason for that, the reason that we did that, is that 1 in 5 GP visits are purely non-medical need, and actually most GPs say it's more than 20%, it's perhaps even 40 or 50% sometimes for them. So people are turning up to their GPs, you know, understandably trusted members of society, you know, a trusted professional that people can seek help from, but people are going there because they've got housing issues or debt or relationships, or they're lonely, or they're socially isolated. And actually, for those individuals, trapping them in the NHS and creating a biomedical solution for them is not necessarily the right thing. They may need biomedicine, they may need referral to other health professionals, they may need a physiotherapist, an occupational therapist. You know, lots of health professionals are still going to be required to support them, but what they may need is just community connection. They may need that support. So those 3 levels of entry point. And then I talk about 4 zones. So that entry point leads to the opportunity of engaging in 4 zones. So arts and culture, sport and exercise, the natural environment, and then advice, information, learning. I've touched on some of those elements there. But I think we can then start deploying those 4 zones in 3 distinct ways. So we've got experience, participation, and intervention. So let's take an example. So take music. So music is proven to be good for us. There's lots of research on this now. I mean, it's huge. There's some really fantastic studies, and there's been some studies recently come out. The WHO have done a lot of work in this with a lot of academic institutions about the benefits of music. So we know that music can have a physical benefit on our bodies. We know it can lower cortisol. We know it can release endorphins. We know it can reduce our blood pressure. You know, it can have an impact on us. There's been lots of studies there around what it's doing. So actually, just experiencing music is a good thing. You know, we might ourselves, we've all got those go-to tracks, haven't we, that we go to if we're feeling unhappy, or we want to motivate ourselves, if we're going to, you know, wanting to get out, get ready, you know, putting music on when people come round to the house, you know, when you're in your car, singing along. You know, experiencing music is a really good thing for us. But actually, there's a higher level that can be unlocked by participation. So singing in a community choir, getting involved in peers, you know, creating that opportunity of community, singing in a choir, using music in different ways for different people. You know, that participation is really, really important. And then a higher level of actually using that music as a form for a therapy to particularly target something. And one of the things that you may have heard of that's been brilliant in the past few years has been Project Breathe by the English National Opera, working with people that had COVID, who had lung damage as a consequence of COVID, and actually using opera singers, professional singers, to basically use music and singing and breathing techniques in order to improve lung capacity. And Imperial College have done some work and proving that clinically that's just as effective as going for formal pulmonary rehab. Now, actually, you know, if you're recovering and you've got your lungs that are damaged and you want to improve your lung health, going to a hospital, being in a clinical environment, doing exercises at your kitchen table on your own, you know, doing breathing exercises, or joining a choir, meeting people, singing, enjoying that, having that societal connection as well, you know, Some may want the former, but you know, it's a great opportunity to have this as a mixed bag of things. So that's how social prescribing model works. That's how the sort of the work comes together. So the way in which this operates, then, what we've got is a model that I think now needs to be deployed at scale to people. So this is a very different take. As I say, we're not saying that drugs and medical interventions and all of that traditional healthcare isn't what we need anymore. Of course it is. We've got to have that. You know, that is what gives us real strength to be able to move forward with treating many conditions and many diseases. However, if we look at multimorbidity, if we look at the complexity of people's lives because of an ageing population, we look at the challenges that modern society brings, we look at some of the challenges because of the social determinants of health, and we look at the limitations of biomedicine, we've got to find a different way. And that different way is engaging with people differently by delivering personalised care, giving them choice and control, and then through that, looking at ways in which we can improve their health and through psychosocial support and through different methods of deploying NHS resources that give those individuals what they need. And that's where I think that we've got a really exciting third revolution in health. Beyond those first two that I've talked about, this gives us an opportunity to take health forward in a very different way. The really exciting thing is we've now delivered this model to 6 million people since 2019. We set ourselves a target of 2.5 million people benefiting because it was a big venture. This was a huge undertaking. But we've now got 6 million people benefiting from personalised care. And with social prescribing, we've actually provided 1.8 million people with a social prescription over the past year as well. So again, it's growing in number, but it's still not enough. We need to really rapidly increase that. The really exciting thing about this as well is that this isn't just a movement here in England and the UK. This is now a global movement. So we now have 34 countries that are working on developing social prescribing and opportunities for personalised care in their own areas. And we've been working as part of the Global Social Prescribing Alliance to really scale social prescribing worldwide. And it's fantastic to see lots of countries now embracing this model and starting to take it forward. It was mentioned in the bio that I started the National Academy for Social Prescribing for government because there was a recognition that we should have an independent body here in England that is supporting the delivery and the expansion of social prescribing, and NASP is going from strength to strength as an organisation with research and development and promotion of social prescribing as a thing. But actually, we've just supported the development of the Canadian Institute for Social Prescribing, obviously over in Canada, and working with Australia and Singapore as well. So actually, we've got a growing global movement of people that are all supporting this venture. So there you go. That's a little bit of an insight into why social prescribing is important and how it fits within the context of some of the global and domestic health challenges. I hope that's been helpful to everyone, and I'm really grateful to take any questions either online or from the audience here. Thank you. Thanks very much.
Thank you, James. What a wealth of exciting information, things we're becoming more and more familiar, right? This becomes, I went to the GP the other day, and social prescribing posters were next to it. I was going, oh, social prescribing in my neighborhood. That was it really reaching the people in all parts of the world now. Certainly, this is very active in England. Can I ask whether we have questions from we're going to go for the online questions first, Lucy is suggesting, right?
Someone's got the hand up.
So we have questions already that are asked.
And can I just apologise because we're having a technical issue with the camera, so people can hear us and people can see the PowerPoint, but they can't actually see us.
It's a shame because we look very pretty.
We do. We all look wonderful. So yeah, if you want to.
So we have a question from Eve. Eve.
Does she want to turn the camera on as well?
Thank you. Right. Okay. So, do we have questions online?
Yes, I'm not sure whether. Speak, I think.
Yeah.
Can you hear us?
Yeah.
Yeah. Can you hear me?
Yes.
Yeah. Okay. Great. Excellent presentation there, and really enjoyed the thought process about extending it out wider. And James, is there any sort of work going on around children and young people? Because I did some research with some refugee and asylum seeker young people, and we looked at self-help strategies, and a lot of those self-help strategies were social prescribing. I didn't place that word in my research, but you know, that is what was coming out of what they needed to support them, really. And I was just thinking really about that expansion to young people, because I've been working in mental health support teams in schools in the last year, and one of the major fundamental issues that was coming from that is that actually those young people needed social prescribing, and it wasn't really there for children and young people. It was, you know, it's pushed out to adults, but actually we couldn't really connect with anyone to support them in that way. So I think it's a huge area that could do some expansion. What are your thoughts?
Yeah, so thanks very much, Eve. I mean, it's great. It's a great question, and I think you're right in that actually we haven't done enough in relation to children and young people yet in this area. It has really started with older people. It has really started with adults. And I think that's been because of the fact that it was being used as a mechanism to support general practice and the footfall of people in general practice facing issues like loneliness, social isolation, those sorts of things. And actually what we've got with children and young people is they're not often turning up at general practice for those issues. We know that there are some significant issues. I mean, I think the evidence suggests that the children and young people between ages, or younger people between the ages of 16 and 24 are the most isolated groups in society, actually, and where there's the greatest level of loneliness, rather than older people, which we sort of traditionally expected. So getting to people early is really important. We know that early cognitive development is really important. We know that the arts play a role in that, for example. We know that physical activity, you know, at a younger age can be really important for lifelong learning and development. So we are doing a lot in NHS England to focus on the work that we need for children and young people, specifically in relation to social prescribing. Having said that, there are some brilliant examples across the country where social prescribing and personal health budgets have been used to create opportunities for people. I know there's a programme in Nottinghamshire that's supported groups of young people to form cycling clubs, and providing bicycles for people that couldn't afford a bike, and getting involved in cycling and skateboarding as part of that. And there's also some great work with organisations called Beat the Street, which is getting children out walking with members of their extended family and getting engaged in their local area, so a way of sort of engaging. So there are some brilliant programmes happening, but actually systematically, I don't think we're doing enough yet.
No, and I agree, and it's that concern about that postcode lottery as well, isn't it, again, and what's going on in your area. So yeah, it'd be good to have a look at further expansion, I guess. Thank you.
Fabulous. There's
Thank you, Eve.
Question from Sean as well, I was just reading.
Sean asks, I joined late. Is there a standard screening process to identify people who need or will benefit from social prescribing? If yes, how will this work for self-referral and for children and young people? We have, just to, before you answer this, to say Sean is one of the people who is working, who couldn't be here today, and is working on social prescribing project for digital work. I also want to say that we have a lot of, I'm looking at the audience here, the people in person, we have a lot of people working with young children and young people. So there is a theme there that might be an area for further expansion. But that's a
really good question. So I mean, there isn't a standard process, Sean, around identification of need. Again, for the formal part of social prescribing in relation to a link worker, people will be referred in by their GP or other healthcare professionals that they may be working with. I mean, increasingly alongside GPs to deliver personalised care, we've also put in place health coaches and care coordinators. So there's about 8,500 strong workforce now, about 4,000 care navigators, care coordinators, about 1,000 health coaches. So they would be the people that would be spotting individuals turning up at general practice and making those referrals into the link worker, into social prescribing, and also working with individuals to improve the skills, knowledge and confidence. But nobody at the moment sort of is really targeting children at a population health level, because a lot of this so far has been a bit of a reactive service to those people that are turning up both at A&E and in general practice, and that's not the flow of children in the system. So how can we be more proactive? And I think, you know, asking colleagues here around connection to younger people, obviously in an academic institution, but actually through schools, how can we get people referred into social prescribing, I think is a really interesting concept. And there's been some work done in Bromley by Bow to look at having link workers as part of the school network to provide that support for younger people to be connected to organisations.
Do we have any questions from the people in person? Yeah.
Two roles, I suppose. What are the key challenges that you see link workers finding at the moment with fulfilling their roles and responsibilities? And I suppose also, what resistance, if any, do clinicians get to personalised care? And as an example, I'm just thinking about somebody who actually wants the clinician to make the decision as opposed to being involved in the decision.
Yeah, it's interesting, isn't it? I mean, in terms of the link workers and their challenges, I think you know, as with any new role, it's a really new profession, and you know, whilst 3,200 people is a significant number, they're spread across 1,250 primary care networks and 4,500, close to 6,000 GP practices. So it's actually quite an isolated role at the moment. So, you know, part of that work that we're doing at NHS England is to try and bring link workers together as a community and having regular webinars, creating induction, creating that opportunity for people to come together. And there is quite a vibrant community. But I think the challenge of working in an isolated way, and actually, you know, whilst this is a big revolution, it's still fairly niche compared to the other transactions that we're having. General practice see 1 million people a day. So, you know, this is still quite small scale. And I think that is always a challenge of getting something off the ground. In terms of resistance, it's interesting because I think we've got a cultural resistance to personalised care in some ways within clinical professions. You know, some of it is a challenge to the way in which medicine has been practiced, and as I said in my example, it's also counter to some of the ways in which we need to practice. You know, there are some occasions where you just want people to be able to make those decisions for you. If you're on an operating table, you want the clinician to be very good at doing what they're doing, not necessarily have the best conversational skill to talk to you about, you know, how you're feeling about it. You know, so there are certain challenges there. But actually, I think we've got a societal challenge as well. I think the public perception of what the NHS is, a drug, a doctor, a hospital bed, you know, by and large is quite tricky, because in the future, you know, if somebody's going into their general practice, it may be that the best person to support them is a link worker or a health coach or even a physiotherapist or occupational therapist. I don't think we're necessarily ready for that being an outcome. People want to see a doctor, understandably, but actually a doctor's probably not best to do a medicines review. That's probably the pharmacist in the community. The doctor's not best to give advice on housing. That'll be the link worker and a community organisation. So, you know, changing that channel that people get their support from is actually quite a big cultural shift that we need to make as a society. And actually understanding that there are things that we can do, you know, through that self-referral, self-support window as well is actually quite tricky. And I think the barriers to that obviously are multifaceted. I mean, two of the words that I really object to, there's lots of words I object to, two of the words that I really object to is lifestyle, choice and behaviour. We talk about that all the time. We sort of have this view that it's easy to change a lifestyle, it's easy to change a behaviour. But actually, because of the societal barriers, people don't have those choices. They don't have the control. No one gets up in the morning and chooses to be morbidly obese or addicted to drugs. You know, that's not a lifestyle choice that people are making. So actually getting to the point where we understand clinically some of these things that are going on in people's lives can start to break down those barriers. So I think, you know, there's lots of complexity involved in those challenges for the link worker and the clinical understanding and change as well. Any other?
Do we have any other questions? Either we have a question from Andy.
Are you aware of any schools who work with CAMS and social prescribing organisations who do some of the work that goes on in work?
Yeah, so as I mentioned, you know, some of the examples of children and young people's social prescribing activity do work across CAMS and also look, and you know, there's a lot of work that goes on with SEND children, but nothing at the moment that's systematic. Nothing that's really there. I think there's quite an opening to explore there in how far this could go in that area. Social prescribing is tended to target those people with long-term conditions, you know, middle age up to older, frail individuals, and how we can get them supported with services. And that's partly, you know, that's partly because that's where the pressure is in the NHS, both in general practice and also at the door of accident and emergency departments. But I think, you know, getting to people earlier in the chain is really important. You know, we've done a lot of work this year with shifting support that would traditionally have been provided in the hospital into the community through virtual wards and urgent community response, and trying to get to people earlier in their health trajectory, trying to get people more stable so that they're not falling into crisis. But inevitably, if we can continue that work, it starts to shift down the age curve, and we start to get people much earlier in their health trajectory. Fabulous. Anything else in mind?
I think we have come to an end, right? Is there anything else people want to ask? We have a resource here which we have used up to a point. I think we need to have James coming again when we develop a further idea of working with children and young people, right, and social prescribing, because I think there is a theme here for us. So that's what I'm left with. I'm also left with gratitude for having James here, for traveling through rain and hail and conditions from all the way from down south to visit us. Thank you so much for being here and being generous with the information you're sharing, taking us through the time, from Mesopotamia all the way here, and creating opportunities for the future as well. So thank you so much, James.
Thank you very much. Thank you all. It's been really delightful to be here, and really like all the questions. And yeah, absolutely. I think there is clearly a desire and opportunity to work together and focus specifically on children and people. So yeah, it's been great to be here this morning. Thank you.
Brilliant. Thank you.